Yeah, hi, my name's Simon Judkins, and I'm the president of the Australasian College for Emergency Medicine, but also a very, a Choosing Wisely advocate. I support Choosing Wisely in our hospital, and I'm also involved in the Victorian statewide rollout of Choosing Wisely. And we're at the MCG today at the National Choosing Wisely conference. I'd like to introduce John Bonning. So John's the president-elect of ACEM, an emergency physician from New Zealand, and also a very strong advocate and supporter of the Choosing Wisely program in New Zealand. So, John, what did you get out of Trish's presentation?
Well, really excited to be here, and Trish I heard in Zurich last year at the International Choosing Wisely Forum as well. She's a really, really powerful researcher, talker, presenter, but somebody that's worked at the coalface as well, academic background. And I think one of the main issues that we had today was sometimes where there's a disconnect between science and people, and science and the real world. And she mentioned 3 words around to the way you present this to people, because we're talking about implementation of the Choosing Wisely issues, and somehow with all the science points towards it being great. So the logos, ethos and pathos of this. So the logos is the structure, the science, the behind it, and all the randomized controlled trials and what have you. The ethos being the credibility of the person that's presenting that to you, and then the pathos is the story, the power of that patient narrative, which hopefully can be a positive narrative about how something can be about reducing waste and choosing wisely. So it was really amazing to see somebody with such preeminent research credentials talking about patient stories and what happens at the coalface, particularly in general practice.
Well, I think it was interesting to sort of get that, not cultural clash, but getting that balance between the research, the evidence-based medicine, but also the narrative and the eminence-based medicine.
Yes.
We always use eminence-based medicine in a sort of negative term, but there's no doubt that, to drive change, you need people who are engaged, you need people who can translate the research into reality and actually how you get that to work within your hospital, within your practice, within your community. So I thought that was a really, really interesting point.
Yeah, and it's so important to involve the clinicians. Which clinicians do you see most often? You frequently see nurses and your general practitioner. A lot of this stuff has tended to be a little bit focused on hospital-based medicine, and I think it's great that we're talking about the coalface and general practice where most people get the vast majority of their healthcare.
Speaking of the coalface, I would also like to just give the Australasian College for Emergency Medicine a little bit of a spruik, because just looking around the room, I think you counted 20 emergency medicine physicians around the room who are all championing Choosing Wisely in the hospital system. So that's really encouraging for us to see as emergency physicians really being in the front and centre and the resource stewards in many respects for the hospital system.
Indeed.
So how do you explain that? What's that about?
Well, I think it's because emergency physicians really understand that the healthcare dollar in the public hospital system is limited, and we need to actually ensure that we're using all of our resources to the best of our abilities. We need to maximise every opportunity we have. So we really understand value-added care. I think we really understand that we actually have a responsibility of clinicians who work for the public in the public hospital system, that part of our role is to advocate for the system, and Choosing Wisely is a very, very good vehicle to advocate for resource stewardship in the hospital system.
It's not about rationing, it's about rationalising and not harming our patients. And we're one of the few places in the health sector where there's no limit to the number of people that come into our area. Everybody else can have appointments and nice sort of, border off their inputs and whatever. We've got people pouring in when they're at their most vulnerable, and you've got to do the right thing. So again, it's resource stewardship. There's not an emergency department in New Zealand or Australia that's not currently full to capacity. The flu season is coming up, we're getting flu deaths. So we really are a barometer of the health service where a lot of stuff happens, interest into the hospital, and rationalising this healthcare is just so critically important.
So with that, what are the opportunities with Choosing Wisely for you in New Zealand, and what are the barriers to greater effort?
Well, there's lots of barriers in terms, we talked about the barriers of actual implementation, the barriers of cost, of disrupting standard ways that things have always been done, vested interests, the pharmaceutical industry potentially, and the opportunities are actually about getting people to understand what it really is around healthcare, that they actually can be harmed, and to get them to ask those 5 questions. BRAN, you can shorten the acronym for the first 4. That's what are the benefits, what are the risks, are there any alternatives, what if I do nothing? And then you can add on costs underneath. But remember, it's not about rationing, it's about rationalising. So getting patients know that they can ask and they can question when they're saying, well, you need this scan. Why do I need this scan? Or you need these antibiotics. Why do I need these antibiotics? What is the chance of benefit? What are the risks of harm? What are there alternatives? And what if I do nothing?
I think the other interesting point that you raised, though, John, was that issue about conflict and about the way we do things around here. And one of the interesting points that Trish made was that we need to use those difficult conversations and that conflict to actually break down barriers to conversations and come to a common understanding about what we're all here to do. And so therefore, we might have things that we endorse in the emergency department about not ordering specific tests, but we might get some conflict with other craft groups, with other specialists. So we need to actually have those difficult conversations, and choosing wisely, I think, is a very, very good opportunity for us to break down many of those barriers and sort of break down that sort of tribalism that we have.
And understand the different perspective that people can have in different specialties. And of course, a lot of inpatient hospital specialists see a lot of people with a given disease. Cardiologists see a lot of people with heart disease. General practitioners, emergency physicians see a lot of patients with chest pain, very few of them with heart disease. And we've got to understand the perspective and walk a mile in somebody else's shoes, and then you're a mile away and you've got their shoes. But it's understanding that perspective, harnessing that conflict.
Yeah,
there's also that systemic stuff though too, Simon.
The systemic stuff.
Barriers to choosing.
I think so, and I think we. It's interesting, we do battle with this again, this concept that if we front load care, for example, if a patient comes in with chest pain and we do a chest pain panel, there are schools of thought or some people who believe that will actually contribute to being able to assess a patient and get them through the system quicker. In actual fact, I think we've got it the wrong way around. I think what we need to do is go back and, as John said, sit down with a patient for 5 or 10 minutes and we can work out very, very quickly what the patient wants, what their concerns are, and often, having that 5 or 10 minute conversation means we don't have to do any tests at all. So I think, in a busy system, we do sometimes get things the wrong way around. We don't need to order a CT scan on everybody who comes with a headache. We can have a conversation with them, work out exactly what they want, rule out the serious pathologies just on history and examination, and send them back to their GP for review. So I think that is sometimes that desire to do more because it just seems like things are that the pressures to do more and more and more. I think sometimes we just need to step back, have a bit of a breather, and have a chat with the patient, and you get a lot more out of having a chat with the patient as opposed to. Most patients don't want a whole lot of investigations if they understand why that's not necessary. So I think the whole choosing wisely move is, again, really about partnering and collaborating with patients about their healthcare choices.
And more is not better, and there's good evidence to show that shared decision making does not take more time.
That's right.
Sitting down, talking to the patient, making a decision with the patient doesn't take more time. It's slightly more potentially cognitively challenging for everybody, but have those decisions and they can be incredibly rewarding.
That's what doctors are there for, aren't they?
Absolutely.
You both very much.
All right.